lot of topics, how to manage complex cases in our daily practice. I will share some of my protocols that I use in my clinic and how I deal with such cases. But before we start, I have to thank ET's company for this opportunity to talk with all my friends and colleagues that I already met all over the world. And we have to say that together we are strong. Yes, we have to fight this virus. We have to fight this COVID virus. We have to fight it. You have to stay home. This is my word to you all. You have or you should stay home to save your family, to save your kids, to save yourself, and indeed to save your country. So from here, I want to say that all my condolences to the countries that are suffering today and suffering these days from this virus. To Italy, Iran, United States, France, Spain, everywhere. We will go through this and together we are stronger. Now, let's move to our topic today. Our topic today will be management of complex endodontic cases. All right, share screen, and here is our, yes. Management of complex endodontic cases with the right tools to gain or to reach the perfect goals. First, before we start, I have to mention the definition of endodontic retreatment by Carr. And in my opinion, it's the best definition for the retreatment. He defined it as a procedure performed on a tooth or a teeth that already received failed prior or previous attempt at or to make root canal treatment. This teeth or this tooth will require a further endodontic therapy to have a successful result. In 1999, we have almost 16 million root canal treatments, and the success rate was between 86% and 98%. So, indeed, root canal treatment is a reliable, good treatment option. Today, we have to divide our incomplete treatment of root canal system into two different types. First type, when the work is shorter than the working length or the tooth length. And this may be due to anatomical problems like curvature or even bifurcation or preparation errors, and this will be our part today. We will focus on this part today, the preparation errors. Maybe it will be a ledge, maybe it will be broken file, and today our topic is how to manage ledged cases, separated file or separated instrument cases, bypass or even retrieve. And the other type is overlooked anatomy, like for example, missed mesiobuccal tooth or even middle mesial canal on lower mandibular molar. So today we will focus on the preparation errors, ledge, broken or separated instruments. First, we will talk about ledge. First, what is ledge? As defined by the American Dental Association of Endodontics, ledge is an artificial irregularity that will happen on the surface of the root canal wall. And logically, it will be on the outer curve, on the outer wall. And this ledge or even this step will prevent us to place our instrument to the apex. And this is the definition by the American Dental Association of Endodontics. And as we always say, the problem is not the ledge. The problem is the area beyond the ledge. As you can see in this X-ray, you can see that we have short obturation, we have a ledge, we have area beyond the ledge that contains all the infected tissues, and that will indeed cause a periapical lesion. So, as we always say, the problem is not the ledge, the problem is the area beyond the ledge. Because as you can see here, we didn't have complete shaping or instrumentation, we didn't have a complete irrigation or disinfection, and indeed, logically, we will not have a complete filling. Now we will talk about our bypassing ledge protocol. All right. If we are talking about my protocol in bypassing a ledge, we have to divide the steps into two steps. The first step is initial negotiation of the main pathway of the canal. And the second step is bypassing or completing the bypassing protocol. First step, the initial negotiation of the main pathway of the canal, which is the most important step. We have to do it with a smart file. In this step, I always use a stiffer file than the normal K file. And I always use the dfinder file. Dfinder file in my hands works very good in this step. And indeed, you can pre-curve or pre-bend your file to have this initial negotiation to gain this catch inside the main pathway of the canal. Once you have this catch, once you initially negotiate the main pathway of the canal, you can, after that, use the normal K file. By the way, in this step of the initial negotiation, I always use the dfinder file in a gentle picking in and out motion or strokes to negotiate the main pathway of the canal. And after that, I will go to complete bypassing step, which I will use the normal K file number 10, 15, 20, and 25 after that to reach the main pathway of the canal up to the apex. Once you have a canal shaped already with K file number 25 taper 02, you can use your rotary files after that to complete the shaping, because after this step, our problem is not the size or the diameter now, our problem is the taper, because we want our irrigation to reach the apex. So after complete bypassing with hand files manually up to 2502, you can use your rotary files. But please here, I'd like to share a trick here, or a tip, is after bypassing with 2502, you should use rotary file 2004 first, then 2504 to reduce a little bit the torsional stresses on the file. All right. But this protocol will take a little bit longer time. Don't we have a protocol that saves time? Yes, we have. You can use with this great endomotor, our warrior, the eConnect S endomotor. In the next video, I will show you how to use this motor with a specific settings, with a specific motion, which will be indeed the reciprocation motion with a certain files to bypass the ledge, even after making a glide path with K file number 10 and 15 only. Now let's go to this video and see how we can use this endomotor in such cases. In this video, we are just how you can use the Fanta ledge correction files, which we are going to use here, with the great endomotor eConnect S. All right, after taking or making a glide path with K file number 10 and 15 only, here is our endomotor with the certain settings for using these files. First of all, we will just choose the mode, the operation mode. It will be reciprocation. The speed will be 150 RPM. And the forward angle or the clockwise angle will be 90. And the reverse angle or the counterclockwise angle will be 30. And we can use these settings with the already pre-bent files, which is Fanta ledge correction files. And by the way, you can also use it in a rotary motion. It will be okay. And that's why the clockwise angle is 90. All right, now, if you activate the endomotor in this motion, you can see, look at the file, it will be just a snake-like motion to negotiate the main pathway of the canal. As you can see in the video here, you can see the tip of the file is searching in a snake-like motion for the main pathway of the canal. And then after that, of course, as we all know, between each rotary files, you have to make good irrigation, copious irrigation, and also you can use the manual hand file to make some recapitulation and check the apical patency if you are one of those apical patency lovers. After that, you can go up in the sizes of the files they have file number 1506, if I remember it right. They have 20, they have 25, and they have 30. Also, you can use it to decrease the level or the limit of the step or of the ledge. Now, as we said, we will just check the patency, do some recapitulation, and go to the next file. You can see here, it's very visible that you can see the tip of the file is in a snake-like motion. You can see here the file will break, the flutes are opening. The break, no, it will not be broken. Because simply here we are exposed to torsional stresses, but the file is big. The size or the core metal of the file is big. So it will be more resistant to torsional stresses. And also indeed, the treatment or the heat treatment for these kind of files are also a very important factor to resist these stresses. Now you can see how we make this apical patency and recapitulation, and you can check the master cone. After that, you have to pre-bend or pre-curve also the master cone to reach your apex easily. Another video here for a case with a ledge. Yes. Here in this case, we have a broken file. It's very deep inside the canal, so I decided to bypass, not to retrieve, because if I want to retrieve, I will be destructive. And after I did bypass, I went to the other canal and I found the ledge. So as we said, the initial negotiation with the finder, then bypassing with K file number 10 and 15 to the working length. And after that, you can see here with the eConnect S endomotor in the reciprocation mode, the settings again 90 forward and 30 backward and the speed 150. You can see here this drop. This drop inside the canal is when the tip of the file is inside the main pathway of the canal. And in this video, I will show you the amount of debris accumulating outside of the canal because of the great design of the files, of the flutes of the file, that really increase the amount of debris that are taken out or go out from the canal. Now, yes, we zoom here, you can see the amount of debris accumulating outside the canal. All right. And this is the way or the protocol that I always use in my clinic in legit cases. First, initial negotiation with the finder number 10. Once I am in the main pathway of the canal, and I check that, by the way, by X-ray indeed. And after that, I go with K file number 10 in a watch winding motion, K file number 15 in a watch winding motion, until I reach the apex or the working length. And then after that, I start to use Fanta ledge correction file in a reciprocation motion, as I told you, the settings in eConnect S endomotor. That's why I really like this combination. As we said, right tools to have perfect goals. All right. Now, I have to tell you that we have a lot of treatment options or even instruments to use in legit cases. Some colleagues prefer ultrasonic in reducing the ledge and to bypass it. But we have to know that if the ledge is visualized under the microscope, yes, you can use it, and you can use the ultrasonic tab. It will be more faster, it will be more easier indeed. But if the ledge is visualized under the microscope, you will use it. And in such cases, my favorite tool is Ultra X from ETs, and we will talk about it even in retrieval cases after that. And I use it in the lowest power to decrease a little bit the ledge. So now my secret weapons in legit cases, as we said, if I can see the ledge, indeed I will use ultrasonic, Ultra X in the lowest power, and you will gain the main pathway of the canal and decrease the ledge a little bit. If I cannot see the ledge under the microscope, I will just do my protocol as I told you. Initial negotiation with D finder, then bypassing with K file number 10 and 15, then indeed I will use phantom correction files in the reciprocation mode with eConnect S Endo motor. All right, now we have a case for a ledge. You can see in the preoperative X-ray, we have short obturation. And if you see the second picture with the mesial shift, yes, here we have a missed canal, we have a short obturation, most probably you have a ledge, and most probably in cases with short obturation, you have to think or to expect that you have a ledge. Here in the cone beam CT, you can see we have a ledge, and indeed cone beam CT helps us too much in such cases with ledge. And you can see here the periapical pathosis. Then I removed this part of Gataberka, and here the ledge is confirmed. And after that, I used the D finder for initial negotiation, completing my bypassing to 25 manually in this case, because at this time I didn't have phantom correction files, and I didn't have the eConnect S at that time. So I bypassed up to 2502 manually with hand files. And then I used the rotary file in a normal rotary motion. As I told you, after 2502 manually hand file, I went to 2004. And in this part, I used the TCA technique. If you know the tactile control activation or the TCA technique, here I put the file until the flutes are fully engaged inside the canal, then I activate. I put it without activation in an offline mode, then I activate when the flutes of the file are engaged inside the canal. And here in the two mesial canals, I shade up to 3004. And here is the obturation you can see. Here is the obturation with the mesial shift. And here is the follow-up after 3 months and after 6 months. After 6 months is follow-up, you can even see the complete healing of the lesion, as I hope. And this case is about 4 years ago, and the patient is very good, touching wood, and everything is fine. So in legit cases, if you can bypass it right, you will have great results. Now let's move to broken instrument cases. I don't know if everything is fine with the live, but I think so. As the live is going on, I think it's fine. All right. Now let's move to the broken instrument. First of all, we have to know why the file breaks. There are two main causes of the breakage or even separation. I'd like to say it's separation of a file. First, we have the cyclic fatigue, and second, we have these torsional stresses. And indeed, we know the difference between them. In cyclic fatigue, I will not blame anyone but you, because single use will be more relaxing for you and for the patient and for everyone. But for the torsional stresses, I will also blame you a little bit, because we don't need to make these forces in the apical area. Torsional stresses simply is when you put the file inside a small or even a narrow canal, and this usually or most probably happen with these small canals and these small files. When the tip of the file is engaged inside the canal and the remaining part or the remaining chunk of the file is still rotating. That's why the flutes will open and it will be broken or separated due to torsional stresses. All right. Now we have a study by Sataban and colleagues. If you can see this picture, I know that when we see these pictures in textbook, we are a little bit bored from it, but in this study, they stated that that torsional stresses occurred in 55.7%, more than cyclic fatigue. And I just want to show you in this picture, on the right picture, you can see the files there are broken due to cyclic fatigue. But in the left image, you can see the flutes are opening, and even the fracture site is irregular. That's because of torsional stresses. All right. Another study by Prout and Co stated that a lot of factors affecting the cyclic fatigue. Radius of curvature, angle of curvature, even instrument size play a very big role in cyclic fatigue. And this is only in cyclic fatigue, not due to torsional stresses. This you have to separate and to differentiate between them. Another study by Perotti et al., they compared the torsional and bending stresses between brow-taper and brow-file rotary system. I know the conclusion, but here I just want to show you one thing, because we will use this slide in bypassing after that. If you look to the right image, this is the brow-file with lens, with radial lens, which is a feature or a characteristic feature specialized for the brow-file with lens. In the left picture, you can see in the left image, this is the brow-taper. This radial lens will just make our bypassing protocol much more difficult. That's why in cases with radial lens, it will be more difficult for bypassing. All right, now we have to simply talk about factors affecting success and failure or failure about bypass or even retrieval. We have factors related to tooth, related to the broken file, factors related to the operator, and factors indeed related to the patient. First, factors related to the tooth. Type of tooth, indeed. If you are dealing with an anterior tooth, it will be easier to retrieve or even to bypass. Cross-section shape and diameter of the root canal. If you are dealing with a distal root, for example, in a lower molar, it will be much more easier than in a mesiolingual or even mesiobuccal canal. And the position of the fragment, and this is a very important factor. The position of the fragment, we will just classify the separated file cases into two options, not coronal or middle or apical third. No, I will just say before the curve and beyond the curve, because the treatment option will be completely different. For me, as long as I have a broken file before the curve and I have the right tools, the right armamentarium, and the right magnification and illumination date, I will just retrieve it. If I have a fragment or a separated file beyond the curve, simply I will go to the more conservative option or treatment option, which will be bypassed. Let's all know that as long as you can remove the file, as long as you can retrieve the file, it will be much more better. But we have to be more conservative also. That's why bypass came here to be a treatment option. All right. And indeed, the gap between the file and the canal wall, this gap will just leave us a space simply to make bypass or even retrieval. All right. What about factors related to the broken file itself? Indeed, first, type. Is it a hand file or a rotary file? Stainless steel is completely different than nickel titanium, even in retrieval or even in bypass, because of the cross-section at least, or even the taper. And also design and cross-section, K-file is completely different than H-file, and the length. And here about the length of the broken part, it will indeed affect our retrieval option and or even our retrieval technique, and also in bypassing. It's generally believed that nickel titanium instruments are more difficult to remove than the stainless steel files, because they simply thread into the canal because of the rotary motion and the secondary fracture indeed, because nickel titanium, especially in dealing with ultrasonic, are always prone to secondary fracture, and also they lie against the outer wall. And this is a little bit a good thing for bypassing, because when we want to bypass from the inner curve, it will be much more easier because the file is already lying on the outer canal wall. We have factors related to the operator, like patience indeed, the protocol. You have to follow a good protocol. And as we always say in style Italiano endodontics, you have to have a feasible, teachable, repeatable protocol. And this is my mission today, to share to you a feasible, teachable, repeatable protocol in bypassing, so you can have a success rate, a high success rate in your cases in your clinic. Indeed, also knowledge, training, to be familiar with the technique and instruments, to be conservative, and also creativity. But please, be creative. Yes, creativity is good, but to a limit, because sometimes creativity may kill its creator. All right, okay. Here, this picture of the elephant, and I was that elephant maybe just months ago, but I lost some weight nowadays. But I think that I will gain the weight again because of this quarantine that we live. Anyhow, you have to have this balance of the elephant. What balance? You have to have this balance in your mind that yes, you have to remove the broken or the separated instrument, you have to remove the harm, but also you have to be conservative, not to sacrifice a lot of the, as I always say, virgin dental. So you need to remove the harm, but also you have to be conservative. So you should be like this elephant with that balance. All right. What about the factors related to the patient? Of course, the extent of mouth opening, limitation in access to the teeth, and time and an anxiety level indeed. And you have to explain everything to your patient and the complexity of the procedure before you start. And also I have to focus and to stress on something. You have to take your fees completely. In my clinic, the fees for the bypassing is the same for the fees of retrieval. Because honestly, in some cases, you will take more time, and time is money. You will take more instrument for bypassing. And all that, or even the stress, all that is money. So I think that you should take your fees as long as you can because it's really your right to have. All right. Now, why to bypass or even to retrieve? Simply, as we said in Ledge, the problem here also is not the broken file. The problem is the area beyond the broken file, containing infected tissues, bulbar tissues, necrotic tissues, bacteria, whatever. So this area is a problem. I want to reach this area, shape, irrigate, and indeed after that to have a good apical seed. Now we will talk about broken instrument bypassing. First, what is bypass? Simply bypassing as a word or as a verb is to go beyond or around something. And this term is always related to the cardiology department because in coronary artery bypass, for example, they make this bypass so the oxygen enriched blood can reach the muscles of the heart and supply it again. And in streets, when we go, if we have an obstacle inside the street, we have to go beyond it or around it. This is bypass as a word or as a verb. What about bypass in dentistry? As we all know that we are all suspected to broken file cases, either we break or even referred to our clinics broken or separated. So we should know how to deal with such cases. When to bypass? Simply, when it's more conservative. As you can see here, the file is beyond the curve. You cannot see, for example, and indeed, if you have lack of knowledge and instrument to make the retrieval. All right, how to bypass? And here is the catchy part. Everyone is waiting for this part. I have to tell you that prevention is better than cure. Like we are all doing now, we are staying home, we are at home, not working, not going outside to prevent us from get infected by this virus. So the same here, prevention is better than cure. You have to prevent or decrease at least the amount of broken file or separated instruments inside your clinic first. Then if we have a case like that, you have to know how to. All right. Now we are going to talk about our bypassing protocol, the catchy part. But first you have to know that this protocol, I hope, will help you to be feasible, teachable, repeatable protocol. Now, first step of our protocol is patient management and communication. You have to tell your patient everything. You have to tell the patient the complexity of the case. You have to, it's better if you have an early appointment, you are not still fatigued, you are in the full mood. If some music will help, it will be okay. So this part is really very important. And then after that, you have to have a good preoperative X-ray. This is a really important step. A preoperative X-ray will help you to know the position of the broken file, the direction of the curvature, and indeed it will give you haphazardly or randomized length of the broken part. Then after that, you must have a straight line access to the broken file. So we make this flaring either with orifice openers, or even in the past we did it, or even nowadays you can do it with gates Glidden, maybe number 1 or 2 or 3. All right, okay. After that, after this step, we are going now to deal with the file. As we said in Ledge, we have to divide these 2 steps: initial negotiation and then bypassing. Initial negotiation, or to gain a catch with the D-finder also, because I don't prefer C+. C+ file is a good file in calcified canals, but in such cases, if you are going, for example, to make the catch from the outer curve, and you are then using the C+ files, and I will show you cases with perforation happens after that, for dentists trying to bypass, and they bypassed from the outer curve, and then with C+ file they made the perforation. That's why more safe to use the D-finder file in a gentle picking motion, in and out strokes, gently to gain a catch. And once you have a catch, please move to the bypassing step, which we are using in this step: K files, normal K files, number 10, 15, 20, and 25. We said in Ledge cases that you can just have a glide path with K file number 10 and 15, and then move to the rotary files or Fanta Ledge correction files at that time. But here, I have to tell you, you must bypass the broken file manually with hand files up to 2502 at least. If you are going to use rotary file after that in bypassing your cases, you have to reach at least 2502 manually with hand file first. Then if you are going to use a rotary file, and I know that a lot of people are scared and afraid from using rotary files after that. But nowadays, we have a great advancement in files, and with this new heat treatments, and it will at least decrease the opportunity to be separated. So after reaching 2502 manually, you can use the rotary file 2004, then 2504. And I tested that a lot in a lot of cases, and thanks God I never had a secondary fracture near to the first file, as long as you are using these steps as we said. And here, the irrigation, as I always use, and the initial negotiation is sodium hypochlorite, and in the bypassing is sodium hypochlorite. I do not use EDTA solution in the first step or even the second step. I only use EDTA solution in removing the smear layer after I complete my finishing, if you are one of EDTA solution users. All right, because I'm a little bit afraid of perforations or even make a ledge or worsen the case. So generally, this is our protocol in bypassing. I hope you got it well. Now we will have some cases of bypass. First, this case, we have a separated file in the mesiolingual canal. The file is beyond the curve, case is necrotic. So I decided, and you can see the length of the root. So I decided simply to bypass. And here you can, as we said, coronal flaring first, to have direct access to the file, then catch with D-finder, bypassing with K file number 10, 15, 20, and 25. And after that, with 2004, 2504. And you can see here is the obturation, and you can see this apical ramification or apical lateral canals, or whatever we can define it or even name it. And we have, you can see here, the getaburka bypassing the broken instrument or the separated instrument. And I hope that I had a good apical seal in this case. Another case with a broken file here, also beyond the curve, and we did bypass, and I was lucky in this case that the two mesial canals are opening together, so it was very easy for bypassing and even for obturation. Another case here, after I made the bypassing, you can see while I'm doing activation of the irrigant, the EDTA solution, and as the last step, the file jumped out. And this is what we call bypass to retrieve. And I was very lucky in this case. The file jumped out simply. And by the way, a retrieval option or a retrieval technique is to bypass the broken file first, and then it may jump out during activation. Another case, which is this patient was a dentist and his tooth, he wanted to save his tooth, and I told him, all right, as you choose this option, let's give it a chance. You can see here a nerve approach is broken inside the canal. I don't know why a nerve approach in a necrotic case, but anyhow, it was very, very easy to bypass. But the problem here was not the bypassing. I was very afraid to push the nerve approach beyond the apex. That's why I always say, if you are one of these or of those apical patency lovers, please maintain maybe only with K file number 8. If you want to make apical patency only with K number 8, even 10 to be safe. And you can see the master cone and the post-operative with distal shaft, with mesial shaft, about 2 or 3 years away or in the past. And touching wood, the case is very good, and he didn't make even a complete coverage with a crown up till now. Another case with a small broken file also in upper second premolar, and here we are not afraid of bypassing. Bypassing was very easy, but we are afraid of pushing this file beyond the apex. And as I told you, maintain your apical patency as small as you can, it will be good. Here, a case with a broken file, and I decided first when I saw the preoperative x-rays that I will retrieve it. But as we know that these x-rays are two-dimensional x-rays. After I opened the case and I removed the getaperca, and after the coronal flaring, I cannot see the file. So I shifted from retrieval into bypassing immediately. And as you can see, I bypassed it manually and with rotary file, and you can see here even with the master cone, but after that, the file, when I was removing the master cone after the x-ray, the tip of the file, or sorry, the separated file was pushed down more inside the canal. But because I always maintain my apex or my apical patency as small as I can, the file didn't go beyond the apex. In such cases, I again do bypassing, but not to the same size with the file I am bypassing before. I will just, for example, here, I did the bypassing first with 3004, up to 3004. Here, when the file was going or pushed down, I made the bypassing up to 25 manually first, only. And then after that, I put the 25, you can see even in the x-ray, and here is the obturation. Okay, last case of bypassing with 5 broken, I know that you know this case, with 5 broken files inside the mesial root of lower first molar. I was very lucky that all the canals in the mesial anatomy complex of the mesial root are opening all together in one apex or one portal of exit. And here is with master cone, here is obturation. You can see the obturation with mesial shaft, and here is the great mesial root complexity or anatomy in the mesial root of a first molar. All right, now we are going to go to broken instrument retrieval or broken instrument cases or separated instrument cases. First, we have to know when to retrieve. Simply, if the fragment is accessible, as we said, if the fragment is before the curve, and you can see it, you have the right armamentarium, you have the right tools, you have the right magnification, so you will go indeed to retrieval. As we said, as long as you can retrieve, it will be better. All right. First of all, this retrieval case, we have a broken file inside the medial lingual canal of lower second molar, and we retrieved it with ultrasonic, with Ultra X, and I will show you in the end of this lecture a video of my protocol in retrieval nowadays. Because as we know, most of the separated instrument retrieval, we can do it with ultrasonic only. And I was using I used to use E25 tab, or the ultrasonic tab, to retrieve my broken files. But honestly, after I use the Ultra X with the small tabs, the great tabs, 2002 and 2502, you cannot even imagine how conservative and how great vision you will have under the microscope, and how conservative you will make this radicular access to the broken file, or even to save to stretch. So here I just removed it with Ultra X, and you can see even in the obturation X-ray how much it was very conservative. It was a C-shaped canals, and you can see a lot of connecting canals, but the apex is one. Another case, here is the apical magic, and it was obturated by bioceramic sealing. Retrieval case number 2, you can see here a broken file before the curve, very simple, very easy, but look at the obturation X-ray, it's very, very, very conservative. You can see the amount of access to the broken file, and then the shaping after that, it was very conservative. I always use, if I want to talk about the staging platform, I always use it with Gates-Glidden number 1, 2, maximum 3. Another case, this case with 4 broken files. The patient is a dentist, the previous dentist is a friend also, and he did break a file, and he tried to bypass it, then it was broken again, and he tried to bypass, and after all these trials, he had now 4 broken files. All right, I started, and as you can see, the broken files, the 4 broken files, it was removed, and here is, you can see the obturation, and the follow-up is very good. Here in this case, also the patient, I know him, and the previous dentist, he contacted me and told me everything about the case. He did break a file, he tried to bypass the first one, and the third one, and 3 broken files, if you can see here, and he insisted to bypass them with C+5. Then, as you can see, he made a perforation. It was not an easy case at all, because even the second premolar was a little bit mesially shifted or mesially drifted inside the mouth of this patient. So the case was not easy at all, even for dealing or handling with these broken files. But I was able to remove the 3 separated instruments, and after that, as you can see, I closed the apex, and also I closed the canal with MTA. Then after that, with Gataberka, indeed. Retrieval case number 5, here you can see this patient came to me with pain, with pain in a lower second molar, and you can see after X-ray, we have a broken file beyond the apex, and in such cases, I always prefer to hold the broken file with a holding technique, for example, the BTR pen. You can use the wire loop technique here. And in such cases, I will show you in the video in the end of the lecture how you can use it to remove the broken instrument. Here is the X-ray of the case after removing, scouting, master cone, and the obturation. Another case here, if you look at the X-ray on the top of the right image, you will see that we have missed canal, we have a broken file, we have a ledge and short obturation. We have everything in this case. So we removed the file, we obtained the main pathway of the canal, of the ledge canal, and we removed all the gataperca, and also we have a direct access to the apices of the two roots. And here is, you can see, here is the obturation, and the follow-up is really fine. Retrieve case number 7. If you can see or look at the image and also to the broken file inside the mesial root, we retrieved this file with Ultra X. And if you can see, the two mesial canals are opening together. When I started to remove the file with ultrasonic Ultra X inside the canal, the file is starting to go deeper. So in this case, if you look at the right image in the top, I put a gataperca cone on the other canal, and when I started my activation near to the file is not going deep. It just went deep to stroke the gataperca and then outside the canal. So in such cases, my tip here for you, if you are going to deal with the type of canal anatomy, please put cone or a gataperca cone on the other canal before you are using the activation of the ultrasonic inside or near to the file. All right, here is another case with a broken file very deep inside the canal. I'm here just to show you that this is my new protocol in retrieval with Ultra X and with BTR from Circumet. I can do a lot of conservative retrieval cases. You can see here, you can even imagine, oh my God, in such cases you will have a complete destruction to the root. I will show you now the post-operative X-ray. Here's the post-operative X-ray. Indeed, it's not perfect as if you are doing just root canal treatment or even this conservative shaping, but I was really conservative in removing this file because of the great Ultra X steps and the great BTR pen for retrieval. Case number 9, and I think this is the last case in retrieval, and then after that I will show you the video of retrieval. Here we have a preoperative X-ray showing that we have a broken file beyond the apex on upper secondary molar. And by the way, this patient was my assistant doctor, and up till now the tooth is good with her and everything's fine, but I have to show you that when she came to me, they told her that you have to make an apical surgery. They didn't even open the tooth, and they just make an X-ray and decided it will just need apical surgery. When she came to me, I told her if I can do coronal buildup and a wall buildup and we can isolate the tooth, we will give it a chance. Then after I opened, it was just, the file is just moving because the previous dentist tried to remove it without the right magnification, and he just drilled a lot inside the canal, and it was very easy to remove. Just I grabbed the file and removed it with Zomex tweezer. It was very easy. Then after that, you can see in this second X-ray, we retrieve the file and we make scouting, and you can see that we have deep apical, deep apical split inside the canal. Here is the master cone X-ray. Here is the obturation for the apical split. Here is after complete obturation with shaft, and here is the obturation. You can see the apical lesion related to the tooth. And here is the follow-up. 1 year follow-up. You can see the complete removal or even the complete healing, I hope. And touching wood, the tooth is good and the patient is still using it. Now, I have to show you that this is my retrieval protocol nowadays. After staging platform with Gates glitter number 1, 2, 3 maximum, I will just make this ultrasonic troughing definition in a counterclockwise motion around the file, between the file and the dentin wall. And indeed, copious irrigation is very important because our definition will be just dry without a coolant. But we don't want to heaten the dentin and even the periodontal ligament around the root. Again, you can see how very easy to handle this Ultra X device and these steps, these very small steps. It was very, very easy to handle and to use. And to make this space around the broken file, just to make some exposure of the coronal part of the file. So after that, once you have exposed, or once you exposed about 1 or 2 millimeters of the broken file, you can use the BTR pen from Circumet. You can see here, I used the smaller blue, and you can see I'm just taking the file or the exposed part of the file from the outer to the inner curve indeed, and with just moving in all direction. Here you can see, yes, I'm grabbing the file, and here we just remove the file. Very, very only 1 exposure, you can save tools and you can be very good. All right, I think that I finished my presentation, so I'm waiting for everything fine. Any questions? If you have any questions, because I really don't know how to read the questions. Ivy, are you there? Hello. We have 18 questions. All right. All right. I will just read the question.
Okay, thank you, Dr. Waleed Kurdi, for the nice presentation. I have sent all questions. It's around 19 questions to your messenger. Please check.
All right.
Yeah.
I already started to check.
So your turn. Okay.
All right. Dr. Shahram Azimi, 90 degrees clockwise, 30 degrees counterclockwise, does come from your trial error experience Oh, no, only experience. All right. The second question, if I broke file at apical part of canal, it will be closed, normal canal path, otherwise if bypass it, will change the pathway, lead to a ledge. Indeed, that's why I always say you have to use a smarter file to make the bypassing in the apical part. And indeed, not all the cases are trying to bypass the broken file, you will just have success. Indeed, no, not all the cases. We are just here to share a protocol, to have a feasible, repeatable, teachable protocol, so you will have a higher success rate if you are using it. But not all the cases indeed. But at least if you are using this protocol, you will have at least 8 or 9 cases from 10. And I think this is a fine way. So if you are bypassing a file in the apical part, it's not easy indeed, but you can just simply use our technique or my technique, this technique, to bypass the file. And always, as we know, we have this last option of surgical intervention. But we have to try first. And if you are trying bypassing and you can feel that you are not in the right pathway, you should stop immediately. Third question, how does ultrasonic help in bypassing ledge? If you can see the ledge under magnification, and I am saying here only if you can see the ledge, it will be very easy to remove the ledge step with the ultrasonic against the outer wall or against the ledge, just like brushing motion, and you will just decrease the amount of the step and it will widen the main pathway of the canal. Which type of ultrasonic used to correct ledge? For me, I'm always using the Ultra X if I can see the ledge under the microscope. This tab, if you want to, you can use, they have 3 tabs. They have the silver one, the gold one, and the blue one. The gold one and the blue one are stainless steel, and the silver one is titanium, nickel titanium. So I think in my cases, I always use this gold one and silver one. The blue one is a little bit more flexible, and you can even use, but I use it more for activation of the irrigant. Question number 5, in very curved canals, more torsional than cyclic fatigue. Why? In very curved canal, no, I didn't say that at all. In very curved canals, indeed, the cyclic fatigue will be more than torsional stresses. Torsional stresses is only, as I said, the tip of the file is engaged inside a small, non-patent canal. So the remaining part or the remaining chunk of the file is still rotating. This is the torsional stresses. All right. Why bypass better than retrieval? Why not act like metal post? All right. Bypass is not better than retrieval. We have to know that. Bypass is a treatment option in dealing with separated file cases. It's an option which is more better in some certain cases. When you have a file broken beyond the curve and you cannot have a good vision, you cannot have a good access even with the microscope, so immediately I can say that bypass will be more conservative. I cannot say that bypass is better or retrieval is better. No, it's according to the case, according to the position of the separated file. Question number 7, it would be great if you make us a brave demonstration of the eConnect programs. All right, we can make another webinar maybe, or another live demo, even in my profile picture or even with ET's page for these programs. How can I control bypassing beyond the curve from the inner surface, not the outer, and to make sure the strip perforation doesn't occur? Nothing here is absolute, but as I said, once you gain a catch, I don't know if I said that or not, once you gain a catch with D finder number 10, you go to make an X-ray. Indeed, If you are bypassing from the inner curve, it will be easier because the broken file will just direct the bypassing file to the right apex. But what if you are bypassing from the outer curve? You will not bypass, or you will stop bypassing it? Indeed, no. You will just be more careful during your bypassing. That's it. And that's why I'm using DFinder, because the tab is not cutting tab, and it's much more safe than C++. But that will not to make you any sure, or even sure that you will not have it. You may have strip perforation even after all of that. I see that ledge are too difficult to deal with when combined with main canal calcification. How to cope with such cases? Same protocol, yes, indeed. Ledge cases are in cases, or ledge in cases with a calcified canal, it's not easy to deal with, but with the same protocol, if you cannot make the right way to the apex, or even to drill inside the canal, the main or the right pathway of the canal up to the apex, as we say, we always have this last option of surgical intervention. And by the way, here, I have to tell you that DFinder in my hands with a reciprocating handpiece, they do miracles, honestly, inside the canal. DFinder with reciprocating handpiece, like M4 handpiece, for example. When can I say that my bypass is successful? It's very easy. Indeed, when you do your bypassing and you reach the apex, and you will know that with the apex locator, and also to confirm with an X-ray, yes, you did bypass. But do not be deceived. When you have the first file, or K file number 10, for example, bypassing the separated instrument, because if you are in a hurry, maybe you will just break the other file. So your bypass is successful. I think that the question is a little bit when to stop, if I'm right. When to stop, simply according to the shaping protocol, or the shaping school you follow. Some people prefer 2504, some people prefer 3004. According to the shaping protocol, or the shaping school you are following, just end on it. As I told you, I just reached you to 2504, and then after that you are free to do or to stop in the shaping size and taper you want. Is there any advice how to bypass a broken file that tightly engages to the canal wall and not to push it through the apical foramen? Thank you, regards from Indonesia. As I told you, the same. I don't think that you just heard, or maybe you came late on the live, but the same protocol as I said. What do you mean by inner curve? Inner curve, if you have a curved canal, we just have outer curve and inner curve, outer curve or outer wall from the curvature, and the inner wall of the curvature. This is the inner curve. Does a separated file become a bit loose during this process? What process? If you mean bypassing, or what process? I don't know. If you mean during bypassing, yes, a little bit. The file may become loose, and in such cases, it will be much more easier either to be pushed deeper, or even to be removed if you are lucky enough to be removed during activation, or even during removal of the file. How can you catch the file after its looseness? What file? Because I cannot understand what exactly. How can you catch the file after its looseness? In what case? If you are talking about the retrieval, I just catch the file with PTR pen. How to retrieve I did already. It was questions before the end of the live. I already put the video how to retrieve the broken file. Is the file separated in the area of ledge? How we can do about it? Separated in the area of ledge. X-ray will help you a lot in such cases, and also combine CTs if you can do it. What is the protocol of retrieval? As I said, first, staging platform with gates Glidden 1, 2, or even 3 to have a direct reticular access to the broken file. Staging platform with a modified gates Glidden 1, 2, 3, or even sometimes 2 is enough. And then after that, I make this ultrasonic troughing around the separated instrument in a counterclockwise motion. And once I expose 1 or 2 millimeters from the broken file, I start to try the BTR pen to grab the file or the separated instrument out. You ask us to use D-Finder for bypass, either ledge or file for both, in ledge cases and even for separated file cases. Sanil, haha, how are you? I hope you are fine. Few questions. How you decide your reciprocation angle? As I said, it's just my experience. How do you use ultrasonic in ledge management? As I said also, if you can only see it. How to confirm your instrumentation and your instrument presence on inner wall and not outer? As I said, X-ray will help you, Combeam CT will help you, but even if you are not in the inner wall, you are in the outer curve, you will just try to complete your bypassing. How to manage tightly engaged instrument in calcified canals? You can use, you mean for retrieval or for bypass? If you are talking about retrieval, I think I just explained my protocol in retrieval. How to manage or overcome metal-to-metal fatigue in bypass with the rotary instrument? You can use EDTA gel, but it will just not completely remove this metal-to-metal fatigue, but it will decrease a little bit this amount of fatigue, but it will not remove it completely. Any alternative to D-Finder you like? Honestly, you can use anything. And in some hands, you can use even pilot files or even C+ files. I'm talking here about what is good in my hands. This is only my protocol. Just I'm sharing my protocol here. If you don't have a D-Finder, you can use RPilot or even C++, but I do not recommend C++ because it's a little bit may make the perforation or even the ledge faster. Peter, please, can you tell us how to avoid canal transportation with rotary file after bypassing the ledge with manual files? Canal transportation. Yes, as I said, after you made the bypassing with manual files 2502, then you can use, if you are using the rotary file, not in the reciprocation mode, if you are using a rotary file in a rotation motion, as I said, TCA technique. You put the file, recurved, and the rotary file inside the canal, and you bypass the ledge, and it's not activated in the offline mode, not activated. And then once the flutes, once you are bypassing the ledge, and once the flutes are totally engaged, you switch on or activate your end motor. Imad Albert, types of ultrasonic tips and the best for your opinion, some tricks about it. All right. About the Ultra X ultrasonic tips, we have 3 tips. We have the gold one, silver one, and blue one. The gold one is very, very good in retrieval and also in dealing with such ledge cases if you want to correct it. And the silver one is very good also, and but more in activation of the irrigant in straight canals. And the blue one is more flexible, and you can use it to activate the irrigant ultrasonically in curved canals. So we have 3 tips. The gold one, better for retrieval, and the silver one, better for activation in straight canals, and the blue one is better for activation in curved canals. Fatima, what is the least magnification shall we have to retrieve a broken file in the apical part? At least microscope, an operating microscope. Because of course, if you are using a magnification loop, you will not have any idea to see the apical part, or you will not be able to see. Muad, how to detect the deep split and the best way to obturate? I detected the deep split in this case just with magnification and scouting indeed with the small K files. Ahmed, what would you do if the file was pushed beyond the apex while trying to retrieve or bypassing the file, especially if the apex is already wide or violated during instrumentation? All right, in such cases, I will just make my obturation very well to have a good apical seal, I suppose, and the follow-up. You have to have a good follow-up, and you have to tell your patient about that. And if you are seeing, or if you see that the follow-up is not good, or the signs or symptoms started to happen, I will just go to the surgical intervention. Because it will be different from some cases with vital, because the preoperative condition of the tooth here will have a great effect on the prognosis. What I do if there is a false pathway? As I told you, if there is a false pathway and you cannot deal with it, or you cannot even seal it, you have to go to the last option, which is surgical intervention. Firdaus, can I do bypass any side of wall inside? Yes, yes. I just said that yes, you will just gain a catch and make an X-ray to know if you are in the inner curve. You will be more lucky and more easier, more easy to bypass. If you are in the outer curve, you have to be more careful. Can we bypass a ledge or remove a broken file instrument without having ultrasonic and microscope magnification? Lailan Sami, this question is really, really, I don't know what to say, but no, you cannot remove a broken file inside the canal, especially in deeper parts of the canal, without microscope and magnification or even ultrasonic, because ABC of advanced endodontics is magnification and illumination and ultrasonic. So I think the answer for this question is no. If the file is separated in the outer wall, it's relatively easy to bypass in a curvature. What if the file separated in an inner curve? There is more chance for ledging during OPA. Indeed. Please enlighten bypass of an instrument in an inner curve. All right. For this question, as I said again and again and again about the bypassing protocol. Once you gain a catch with the D-Finder file or any stiffer file than K files, but in my hands, I always use D-Finder and it's the best in bypassing in my hands. Once you gain a catch, go and make an X-ray to know if you are in the inner curve or even the outer curve. And in the inner curve, it will be much more easier. If you are in the outer curve, it's not a problem. Just be more careful and just use the K files, as I said, in a watch winding motion, and do not push your file inside the canal. That's it. So if you are dealing with bypassing, you will just deal a little bit with luck, because you don't know where is the catch you will have from the inner curve or the outer curve. We are trying to simplify things. We are trying to make a good protocol, a good, feasible, teachable, repeatable protocol, as we always say in style Italiano endodontics, so you can use to have a good and more good, successful prognosis in your cases. I hope I did answer most of the question or even all the questions, and you can follow my page or even my profile and ask anything, anytime. And I hope you did like the lecture. And again, I have to thank Etis, because really we are stronger when we are together. Together we are strong. And please stay safe, and may God bless you all. And Ivy, are you there? Hello, Ivy.
Yes, Dr. Kurdi.
Yes.
So we think, thank you for your presentation and replying the questions. I think it is enough now. Yeah. Thank you so
All right.
much.
Thank you.
Yeah. Thank you.
Bye-bye.
Bye. Quit Zoom 是吧？